Okay, everybody, we are getting started. So, John, everybody, please. Thank you for your attention. Well, let me first start with welcoming all of you, our audience here, but also the audience online, to the 20th Observatory Venice Summer School, which is, of course, something we will celebrate together with you today. The topic of this year's summer school is paying for healthcare in the face of fiscal constraints, a topic I think we chose well because the attention for it and the interest in our summer school was enormous. And thank you also for joining us today. And we have, I believe, many people also following us online. We will have a panel later, but we'll first start with some welcome remarks from the organizers of the summer school in the last years. And I would also like to say a few words about the summer school. Obviously, we've had more than 1,000 participants over the year. I keep bumping into people who tell me, I was in the summer school 10 years ago, 15 years ago, 20 years ago. It's been basically a new community and a network with amazing people doing amazing things in health and influencing the health systems for the better. I owe a lot of gratitude to my predecessor, Giuseppe Figueiras, who you know well for the ones who've been visiting us before here in Venice, who's been here every year. He was here also last year, for his vision, together also with the Veneto region, to start a school like this and the enormous success that it has turned into. I would also really like to thank Reinhard Busse, who is the director of the summer school, who unfortunately this year couldn't attend. I really want to thank him for keeping an eye on the quality, pushing us to come up with relevant work and keeping assignments for every participant that are interesting and also fun to do. And that's exactly the tradition that, if you let us, Veneto region, we will do for another 20 years. As I said, none of it would have been possible with the enduring support of the Veneto region. I'm very pleased to also have the minister, Mr. Gino Gerosa, here to help welcome you. And then we'll hear from the other organizers as well. So, Mr. Gerosa, short welcoming words.
Good afternoon to everybody. I don't want to waste your time, so I'll be very short. I'm brand new with the Observatory because I've been appointed as a regional minister of health of Veneto region just last December, the 6th of December. In my previous life, I was a cardiac surgeon, so everything is brand new. My position, my commitments, and I hope that we can have, for the next 20 years, the Observatory here in Veneto region, because that means that probably I will be here for the next 20 years. I don't know. Keep your finger crossed. I'm joking, of course. Okay, thank you and welcome to everyone in Venice to the summer school.
Now I'm inviting Cristina Modoran, who is the head of the Policy Strategy Unit at DG Sante at the European Commission, for her welcoming remarks.
Thank you very much. A warm welcome from on my side as well. Thank you, Minister, for hosting us in this beautiful building and in a city that couldn't be a better place to represent the meeting point for centuries, a city of bridges and connections. And I think this is also a summer school, and at the European Commission, we are very proud to be partners of the summer school and of the Observatory, and to support this endeavor, because health and good health and resilient health systems are at the core of our European values. And we know that effort and work need to go to maintain what we have achieved so far in Europe, and also to bring it further and to make sure that the sustainability of the European way of taking care of the health of its citizens not only survives, but thrives and improves over the year. And I think a setting like the summer school and also the panel this afternoon that is open broader than to just the participants of the summer school is a great opportunity to reflect, to exchange ideas, and to see how we can all contribute to this, this European vision for our health systems. Thank you.
Thank you, Cristina. And now welcome Chris Brown, who is from Venice and from the European Office for Investment for Health and Development here.
Thanks, that's great. So, good afternoon, everyone. It's really a pleasure to be here. It's 20th anniversary celebration of the summer school. I was actually asked to give in a brief today, and that was to think of a success story over the last 20 years that would sum up the impact of the summer school. But, sorry, I'm not going to do that yet. Because I think the evidence of the success of the summer school is that for 20 years, it's remained fully subscribed every year. So in a world where us as health professionals and managers face increasing pressures on time, returning to this program every year provides value and shows that it has its impact year on year. And that is actually in all kinds of health systems across Europe. And just to make three kind of reflections on why I think it's successful. Every year the summer school tackles the issues that matter the most to leaders and practitioners in the health system. So over the years, we've addressed topics such as health financing, workforce challenges, governance, resilience, innovation, and systems transformation. And this year's no exception. Time of constrained fiscal space, growing demands, rising costs, pressure on public budgets and spending. So the question of how we sustain investment in that environment to strengthen health systems could not be more important. Secondly, practicality. And I think I've been talking to people outside, I've been talking to some of the people sitting next to me. What makes this summer school distinctive is that it doesn't stop at discussing what needs to be done. It focuses on the how and the practical. So, as you know, the sessions are highly interactive, grounded in real-world experience, designed to equip all of us as participants and organisers with practical knowledge, skills and approaches that you can take back to work. And this combination of evidence and experience with peer learning makes that resonate long after the week is over. I think there's one final success factor, and that's the partnership that goes behind the summer school. So it's built on a unique partnership model. The Observatory's governing bodies and this summer school brings together countries that are deeply committed to improving health systems, ensure they continue to meet the needs of citizens. So this keeps the programme connected to real-world challenges and emerging priorities. And from a WHO perspective, the partnership is equally important. It enables participants to engage with the latest evidence, policy guidance and innovations across the WHO family. A good example of this year is the way that Venice office and the Barcelona office are putting on sessions on new approaches to financing, prevention and care. And so if you want to know more, talk to John and Odd. I don't know where Odd is. And Odd, okay. And of course, it's no coincidence that we're here in Venice. For many years, the summer school has benefited from the support of the Veneto region, where health systems are recognised for its strong performance, innovation and leadership, both in Europe and internationally. The setting itself reminds us that excellence in health systems is not abstract. It's something that can be built, sustained, and continuously improved. So I would like to welcome everybody. Thanks for being here. We're great, thrilled to be partners, and wish everybody a stimulating week ahead. Thank you.
Thank you very much, Chris. We will go to the presentation of the minister shortly, and John will be the moderator. I just want to thank one more person from the Veneto region, and that's you, Luigi Bettinato, who's been there from the beginning, and always making sure that we connect. And the pizza after the The panel is always the highlight of the week. Looking forward to that already. And so I hope, looking forward to the presentation from the Minister. I'll give it over to John now.
Thank you, Ewout. Thank you, Minister Gerosa. We're very grateful that you have agreed to deliver the keynote lecture for the high-level panel on the challenge of aging populations in the Veneto region. So please, the floor is yours whenever you're ready.
Thank you. So we're going to talk about, let's say, the major risk in a system, in a regional health system like ours, that you know the Italian system is universalistic, it's public, it is only funded on public money. And so we're talking about aging population, technological innovation, and financial sustainability, how we can intersect these three pillars. But before I don't want to annoy you, I just want to make you a little bit sad. So I would suggest for you to read this paper, recently published, Global Human Population Has Surpassed Earth's Sustainable Carrying Capacity. When I read this paper, I was pretty happy that I'm already 70 years old, and so I should be able to escape. I don't know for the younger in this room. So the brochure and the other co-author actually borrow a classical ecological tool. That means the relationship between a population growth rate indicated with the letter R, and these sides indicated with the letter N. When R declines as N increases, a population is approaching its carrying capacity. Now, we have two phases and one turning point. The first phase is facilitation, running from 1800 to 1949. More people, but higher growth rate. Technology and fossil fuels reinforce population expansion. And then the negative phase from 1962 to the current time. Growth rate has declined consistently as population has grown, and the classic ecological signature approaching a limit. So when it comes to numbers, you know, the sustainable carrying capacity is around 2.5 billions, but the maximum carrying capacity is something between 11 and 12 billions. But the current global population is 8.5 billion, so it's already 3 times higher than the facilitation phase estimate, using the equivalent of 1.7 hertz of biocapacity. Now I show you these two graphics, and if you look at the graphic on the right-hand side of these slides, you see that how little, even 50 million death events, for example, due to pandemics, wars, famines, slightly than the long-term trajectory as far as the increase of the global human population. And when he looks at the historical trend and the turning point, you see on the left-hand side, on the right-hand side, of these slides, you can see that the clean shift from a positive to a negative RN relationship, and that's happening around 1961, 1962. You see, up to 1961, 1962, we were using less than 1 Earth in terms of biocapacity, and then from 1962 over, we are using more than 1 Earth of biocapacity deficit. And when we are making a breakdown, a regional breakdown, you see there are no really difference. Just the difference relies on the time of the onset of this phase, from 1957 in East Asia to 2010 in sub-Saharan Africa. Now, the demographic shift, I don't need to annoy you on this data because you know this data better than me. 16% of the world population will be older than 65 by 2050, with the 2 times old age dependency ratio since 1990, and the older elderly people over 80s is the fastest growing age group worldwide. Now, why it matters? Matters because there is a financial pressure. So pension system is under strain, is rising the healthcare and long-term care costs, and also there is a shrinking tax base. What about Veneto? You're asking about Veneto. So the pyramid that no longer exists, you see, we have now an apparent stability because residents in Veneto are roughly a little bit than 5 million, 4,800,000 something. Since 2014, there is a downward trend that is now partially halted. It's 0.03% from 2024-2025. That is a little bit lower than the Italy change, that is 0.05%. Now, this is the decline forecast up to 2050. So we should have something something between 50, 100,000 fewer residents projected by 2040 compared with today. And this can rise up to 168,000 projected by 2050. So this is the ratio between the low birth rates and the rising longevity. So the balance is due to this fact, not only because we are living longer, but also because we have lower birth rates. And if you look at the share of the population aged 65 and more, is passed from 19% of 2005 up to 35% in 2050, is forecasted at that level. The people aged 85 and over set to double between now and 2050. With the older people per child aged 14, that is double in 2025 and is 3 times higher in 2050. So we have lost the broad base of young people relative to older generation, and the imbalance between the working age and non-working age population is becoming even more evident. If you look at the population pyramid in Veneto, see this is 1952 with a broad Ewout base, has changed in 2025, so on these days with a wide adult core and a narrow base, but it's going to be really bad in 2080 because there is a marked imbalance, if you look at these slides, between active and non-active population. It's a column, not a pyramid, you see, with a larger base with the older people. And also, as I told you, Italy is aging faster than Europe. You see the comparison between Italy forecasted, and the European 27 countries. You see that we are aging faster than Europe. But if you look at the share of population aging between 0 and 14 years of age, there is a difference, a striking difference between Europe and Italy. So we are going down from 14% to 12%, whereas Europe is going down from 16% to 14%. What's about the other country? Who is doing worse than us in Europe? So Italy and Spain, they actually share the same experience. Italy and Spain are the two countries most affected by this demographic impoverishment of the younger generation. France is doing a little bit better, performing a little bit better, because it remains a little bit above the European average at 16.6. And remember, was 14 and something for Europe. And Germany, that is below 14, so despite this lower share of young people, shows signs of recovery compared with the past. In summary, this temporary stability that I was mentioning before should not mask a deep structural transformation. The current demographic stability is transitory, aging is the real emergency, and Italy, in this case, is a particular case within Europe when compared to the other. So if we try to put together aging of the population, innovation, and financial sustainability, we well know that those shape one another in a continuous loop. So innovation lowers the cost of care delivery, but longevity drives demand for assistive and health tech. So when it comes to how technological innovation can ensure financial sustainability, we have 3 trajectories. So we have to lower the unit cost of care, we have to extend productive life and offset workforce loss, and we have to improve financial system efficiency. In other words, when it comes to lowering the unit cost of care, telemedicine, remote monitoring, and artificial intelligence diagnostic move intervention upstream, catching a chronic condition before it becomes an acute, expensive hospitalization. And also, care robotics apply the same logic to labor. A robot that supports daily living tasks doesn't replace the need for care, but reduce the human hours required to deliver it. So from a financial logic, care demand keeps rising with age, but if the marginal cost per person falls faster than volumes grow, total spend stays on a sustainable path. When it came to the second trajectory, extending productive life and offsetting workforce loss, we have to keep people active longer and automate where labor is missing, where the workforce simply is not there, caregiving, logistics, manufacturing, robotics, and artificial intelligence fill the productive gap without relying on net immigration or service cuts. And finally, for the third trajectory, improving financial system efficiency. This means a risk transfer to capital markets. Instruments like longevity bonds shift demographic risk of public balance sheets and onto markets better equipped to absorb it. Now, how this trajectory can, I was mentioned before, lower unit cost of care, extended workforce and automation, efficient financial system. All these three channels compound will lead to a fiscal trajectory that bends, not breaks. So spend keeps pace with need, GDP keeps pace with obligations, and financial systems price risk accurately, the combination that keeps aging affordable. Now, the logic is a condition, of course, because none of these three trajectories deliver sustainability automatically. So we have to have we should have a higher upfront investment, and also the adoption should not be uneven. So the key takeaway is technology doesn't make aging cheaper by accident. It makes it cheaper when it lowers the cost of care, extends productive life, and sharpens how financial risk is priced and shared. So sustainability is not a side effect of innovation. It is a design choice about where that innovation is targeted and who can assess it. So going back to this triad, aging, innovation, and financial sustainability, that we said already shape one and another in a continuous loop. Innovation as a response should rely on telemedicine and remote monitoring, care and mobility robotics, artificial intelligence-assisted diagnostic, and digital social platforms. So the path forward is treat aging as a certainty, not as a shock, fund innovation that lowers the cost of care, and redesign financing before the pressure peaks. So act before then something happens. Exactly what I show you with the slides on the sustainability on the earth with the growth of the population. So there are 4 strategic levers. That means health, social care integration. So for a stronger coordination between health and social services for continuous care pathways, home and community-based care, digital health innovation, and fewer avoidable hospitalization and institutionalization. And I'm sure that some of you is very well acquainted with this concept. So we should move from a fragmented to coordinated system, because improved system performance, we can do that by investing in prevention, integrated pathways, and efficiency. And I love KAIST. I'm sure that you know KAIST. KAIST is the Korean Advanced Institute of Science and Technology. That is the first and top science and technology university in Korea. And they had a mission and a vision. They founded KAIST in 1971. As I told you, it's better to prevent rather than to react. So back to 1971, they opened KAIST, and the founding philosophy was all developing countries find the driving force for economic development in science and technology. By the year 2000, KAIST will be a great institute of technology that will have become the model for a number of similar institutions in other lands. And if you look at this sketch, you see in 2019, they opened the first Kenya KAIST project launched. So exactly what they were presuming at the beginning in 1971. So going back to artificial intelligence, you know, this is the Veneto region. We can, because we are shortage of doctors and nurses, we can actually use general control by using artificial intelligence technology, you know, putting together in a network the intensive care unit around the region. And we can do that even in more remote area, more remote lands of the Veneto region on the Dolomites, on the mountain. And I'm not going through this very much indeed. I would thank Chris Brown and Luigi Bertinato, because we are starting with this project. That is a little bit presumptuous, because we would like to have the Veneto Global Health Aging Innovation Lab, the international lab for aging people, a strategic investment case done with the Office of the President of the Veneto region, Alberto Stefani. And I hope in the next 20 years to come back here to deliver the result of this project. We already talked about the demographic shift and why a new approach is needed. Veneto's aging transition is already the daily operating reality for its health and care system, and the cost of not prioritizing it reaches well beyond health outcomes alone. So if we are inactive, if we do not prevent and we do not react, of course we are going to reduce functional ability, independence, and quality of life for older people and the mid-years population alike. We are going to rise in the avoidable hospital admission and mounting demands on already stretched care pathways. Also, we're going to have weaker neighborhood networks and less capacity to support isolated or at-risk residents, and also higher long-term care costs falling on a shrinking working age tax base. And finally, we're going to have a greater loneliness, isolation, and widening inequity between generations and communities. So what the lab will do, I'm just going very quick around this, generate evidence, translate and test on the system, scale and transfer, and then convene globally. Do you agree, Cristina? Okay, perfect. So there are 4 connected categories of impact: improved outcomes for older people, social and community impacts, health and care system impacts, economic and fiscal impacts. Now I'm going to end my presentation. As I told you, in my previous life, I was a cardiac surgeon, and just 1 month before I was appointed as a Minister of Health of the Veneto region, I produced the Carta of Padova in Universum Salus, 15 key points for a collective intergenerational health pact. We published this in the Italian Journal of Cardiology, and I wanted to move from the concept of One Health, circular health, to a concept of In Universum Salus. I'm nothing against the Americans and the British language, but I wanted to translate with the Latin that is not very used, but it was used to be an international language. So I moved from One Health to In Universum Salus, and I moved from the circle of One Health to the neural network of the In Universum Salus, where we are putting together, of course, the ecosystem and the human health. And so there are 15 points: inclusion, the psychophysical social well-being of a community cannot be achieved without addressing inequalities, school education, welcoming inclusion, and the active participation of different groups in terms of gender and age. Environmental protection, attention to the environment is one of the fundamental components of the In Universum Salus concept. You know, the acronym In Universum Salus Ius means in Latin diritto, right to have something, and the Article 32 of the Italian Constitution is granting the health for the people, and that use Articolo 32, so the right to Articolo 32. And therefore requiring attention to biodiversity, protection of common goods, promotion of sustainable mobility, and promotion of efficient environmental policies. The balance between innovation and sustainability. We were talking about this before. Healthcare innovation has enabled early diagnosis, effective treatments, and improved quality of life, but without ethical and sustainable foundation, it could create inequalities and negatively impact the environment and global health. Innovation cannot be separated from economic sustainability, requiring a redesign of the system, re-engineering hospital, centralizing resources, and creating organ-specific regional centers of excellence. The use of artificial intelligence, the health education, the school involvement, the centrality of the person, and go back to the Article 32 of the Italian Constitution, which recognizes health as a fundamental right. The person must be at the center of both social and healthcare policy choices, with an emphasis on the value of the care relationship. Intergenerational responsibility. Each generation must build on the experience of the previous one, including promoting the well-being of future generations, always maintaining strong attention to ethics and sustainability. Global vision, that's why we are speaking of Salute Insieme, collective health, which require considering different interconnected dimensions, physical, mental, environmental, and social. These dimensions involve different actors: politics, community, school, family. Equity, solidarity, and the inclusion of the age, the health factor incorporate ESG issues. You know, corporate have environment, social governance, and my suggestion to include health, the age of health, together with the ESG issues. Enhancement of the liquid hospital and quantum medicine. This is a topic which I believe that Luigi likes very much indeed. And the child first 1,000 days. focusing on nutrition, environment, psychophysical development. You recharge first 1,000 days, promotes the overall well-being of the future adult. So prevention is not going to a luxurious status, but is a must for every health system. And prevention as a pillar of a universalistic, equitable, supportive, and sustainable healthcare system. And then, concluding my presentation, this is the logo of the Veneto region. You know, we have the 3C, that means community. It's not in English C because it's casa, but it sounds like home in English. And then care. So, in Italy, comunità, that is community. There's embracing the casa, the home. That means it's embracing the single patient in order to provide cure, the best cure. And of course, with the concept of in universum salus. Thank you for your attention.
Thank you, Minister Gerosa. That was a very inspiring presentation, not just on the Veneto region and the challenge of aging, but more globally. We don't really have time for questions, but I think we should have some questions anyway. And I wanted to start us off. So I think you very nicely laid out the challenges and this idea that technology will play an important role in helping society and health systems to deal with the challenges of an aging population. Thinking also, as you mentioned, you in your previous life were a cardiac surgeon. So both as from the perspective of the minister, but also from the perspective of a provider, how do you change the behaviors of providers in the way that they treat patients to actually realize this increase in efficiency, get them to adopt new technologies? From your perspective, both from the health system, being the lead of the health system, but also a core actor, what does it take to actually enact change?
I think we should simply move forward from a reactive medicine, you know, you're sick and I cure you and treat you, from a preventive medicine, because we have elderly people, they are chronic with multi-comorbidity, they are fragile, so we have to prevent the acute phase in a chronic situation, because we want to avoid hospitalization of this patient. And that's why we have to take the hospital to the house of the patient, and we have to keep this patient away from the hospital. I think this is a tricky part one, and of course we can take advantage and make the most of the artificial intelligence, wearables, everything that comes in your mind.
Great, thank you. Questions from the audience? Vesna?
I wanted to ask, you mentioned equity also, but introducing artificial intelligence on all of this, how are you going to ensure that people are walking along all this progress and technological progress? How actually are you going to ensure enough health literacy in the population to walk along with your reforms?
Actually, now we have the Casa della Comunità, you know, in according with the M77 from the national law, you know, and because, you know, I'm trying now to translate in English because it's a little bit difficult. Health is not only one Moloch, you know. You have the provided health, the perception of health by the citizen, and the storytelling of health by the other politician and by the media. So one thing, if, for example, I go back to Veneto region, you know, we have the life expectancy that is 84.3 in Veneto region. The national life expectancy in Italy is 83.4. So we have 1 year life expectancy higher when compared to the rest of Italy. Then when you are talking about life with good health, we have 60 years. Whereas in Italy is 58 years. So we have 2 years difference. So when you are talking about health provided, I'm going to tell to the Veneto citizen, you know, you live 1 year longer than the rest of Italy, and you have 2 year higher life in good health when compared to the others. And so this should mean something. Then you have the perception of your health system. With the waiting list for procedure, waiting list for visits, you know, and this is quite long. So if you are talking with a citizen of the Veneto region, would say, the system is not working very well indeed because I have a waiting list too long. So he's not paying any attention to the fact he's living longer. He's living longer in good health status. But that's his perception. What is, and then there is the storytelling by the media. You know, somebody goes to the ER, no, to the emergency room because there's a chest pain. So go there with a chest pain, and the doctor they test him for a myocardial infarction. They exclude the myocardial infarction. They then test him for aortic dissection. They exclude the aortic dissection. They test for pulmonary embolism. They going back to the cardiac surgery previous life, you know. And then they test for pulmonary embolism, and they exclude the pulmonary embolism, and then they discharge the patient. And then the patient, half an hour later, he dies. Why he dies? He dies because he had the congenital cerebral aneurysm that actually was broken. But he actually went in the ER because he had a chest pain, nothing to do. So you wouldn't do a CT scan, you know, brain CT scan to see that. But on the newspaper, they would say he was in a ER half an hour before, they discharged him from the ER and he died suddenly half an hour. So it's a bad health system. So you see there are three different. So to inform, in order to inform your citizens about your system, I think is going to play a major role. Going back to the beginning of my answer, I was mentioning the Casa della Comunità. I want a room in the Casa della Comunità, in each Casa della Comunità in around the Veneto region. I want a room for the very well-informed citizen. And so using, for example, visors or other system, you can deliver messages regarding quality of life, regarding risk factors, regarding screening for breast cancer, screening for colorectal cancer, and also, for example, for the young population, the risk of HIV, because, you know, HIV is increasing because nobody is talking anymore about HIV, you know, and so there is a steep increase. And therefore, I think to inform your citizen will be crucial.
Great, thank you. Other questions from the audience? We also are taking questions online, but we have a question online? Okay, straight from the internet. Please, go ahead.
Thank you so much for your talk. So we have one question here online that says, you referred to the psychophysical health of aging populations. While AI can increasingly support the physical aspects of health and care, how should we address the psychological, social, and broader dimensions of well-being in older age? What role, if any, do you see for AI in supporting these dimensions?
You know, I was visiting a couple of days ago one home for elderly people, you know, and then I asked how many people in this area is older than 75, and they give me the number, some hundreds. And then I say, how many beds you have in this residential home? And they say 28. So I said, there is a huge discrepancy, you know. So I say, why you don't do the same? You know, I call in English asilo, for the little kids, the nursery. Why you don't do a nursery for elderly people? So it's a matter of the local authorities to set up, you know, a transfer from their home to this nursery for care center, and then they go back at home for sleeping. So you are cutting the cost quite a lot because you don't need the bed, you don't need the people taking care of them overnight. But then you can do your physical and neurological training for those people. And that will be extremely helpful in my mind. There are a lot of publications, around this. And so you have to re-engineering your concept, because as I always say, and these things, actually the more difficult things, who said that, I can remember, is to see what is in front of your eyes. And also you should think not out of the box, like everybody say, you should think out of the box, but you should think without the box. But unfortunately, sometimes we're thinking in the box, with the box on the head.
The strong mental image there. Are there other questions from the audience? Yes, Tatiana.
Thank you, dear Minister, for your presentation, very comprehensive. And you mentioned that you will have a lot of investments to make up front. If you could give us some details, how do you plan to secure the funding, since we are in the summer school, on this theme? And how will be the negotiations if you plan to raise more money within the government? How that you plan to do it upfront?
As I told a couple of days ago when we were in San Servo, you know, we have 21 different health systems in Italy because there are is on a regional basis, but the funding comes from the central government. So of course we are trying with all the other Minister of Health of the different regions to try to increase we are now around 5-6%, we should increase a little bit more. I know that there is rearm, but of course you have to decide for a country where you want to divert your money. And this is important. I am not the Minister of Health, I'm not a central government, so one thing it will be to increase a little bit the percentage that they are dividing their support in different regions. And the second, I think that we should look for private funding, for example, from bank and try to, for those programs, for example, I'm trying to have support from the bank. We recently are starting now a follow-up according with the ESG plus age. We are starting next week screening people for cardiovascular disease or screening for breast cancer or colorectal cancer, the employers within the manufacturers, and this is supported by a bank in Veneto region. So those are type of funding.
Any other questions from the audience? Any more online questions? Okay, I think we're actually good on time. Minister Gerosa, thank you so much for
Thank you to you.
a very inspiring discussion and very inspiring presentation. So please applause for Minister Gerosa.
And the most fundamental taking home message, enjoy the pizza tonight.
We will. Thank you so much for your generosity with your time, and I hope you stay with us. So now we have the panel where we will discuss and dive further into the various country experiences, but also the international experience. So I would like to welcome here on the panel, on stage, Valentina Prevolnik-Rupel, who was the former Minister of Health for Slovenia. Welcome, Valentina. Stefan Eichwalder, who is a Deputy Director General in the Austrian Ministry of Health, and I can only say Ministry of Health, but the name is much longer, but it covers it quite well. Of course, also Cristina Modoran, who also welcomed you already from DG Sante. Trin, where are you? Trin Habicht, Senior Health Economist from WHO Barcelona office. Thank you. Ajay Tandon from the World Bank. Lead economist, will provide a good global perspective, I hope. Welcome as well. And I wanted to start with Valentina. I know that when you were a minister, and now you're a researcher again, you were focused also on finding more revenues from general taxation, but also you were looking to find efficiency in the system. Can you give us a couple of examples of the kinds of approaches you used during your ministry? You can, yeah, you should be able to.
Yeah. Thank you very much, and thank you for having me on this panel. Yeah, true. In the mandate, we try to undertake many measures, to make the system, healthcare system, stable. We wanted to assure stability. And for me, it was very important that we could do all the measures to make the services more efficient or the healthcare system more efficient. But then it's a question, what is actually efficiency? What do we mean by that? We've all been talking about this for 20 years, but do we really know what efficiency is? And I think there is more types of efficiency. Actually, one type of efficiency is to make each service as efficient as possible, meaning that it provides better healthcare outcomes by a certain cost or the opposite, you know? That's basically you cannot do this without the healthcare experts, without doctors, without nurses, without the team. As Minister was kindly showing us, you know, the innovations that you put into a certain surgery, be it cardiac surgery, be it whatever. But if you want to make it efficient, you would follow the experts, right, to make it as efficient as possible. Then there is another kind of efficiency when you don't do the thing right, but more do the right thing, meaning that you want to choose those services for the population that bring the best outcomes. So you select the services, not do each service as efficient as possible. I mean, both. So it's both efficiency that you try to pursue. And in that area, it's more the role of the, also the role of the, let's say, ministry or the team at the ministry, at the health insurance, through health technology assessment, which we set up in Slovenia, quality indicators, where to measure outcomes, assure that we have proper healthcare workforce that we try to kind of keep and make happy so that they produce the services. But mostly, I would say that there is something that we are kind of all afraid to say. And it is that we all, yeah, maybe, maybe it's time. That we all know, you know, that we've all known for many years and we've talked about it, but we don't want to really say it out loud. We know what's most efficient. It's prevention, right? And we all know it. It's if we just didn't smoke, if we just didn't drink alcohol, if we didn't do drugs, if we didn't stress, if we moved around more, we would be more healthy. But it takes us all out of our comfort zone a bit, right? It's difficult to take time every day to walk, to make steps, to eat healthy, not to drink alcohol when we celebrate something. So, you know, that's the most efficient thing, to downscale the care, prevention, promotion of health, primary health care. And that's, I think, is something that is most efficient that each minister can stand behind in his or her country during the mandate to promote, prevent, and stand behind such activities.
And it's really an allocative efficiency then angle that you're taking. And I know that also in Austria, Stefan, you've been trying to do that as well. But I also know that you've been adding funding to the budget, that you received more funding only 2 years ago from the Ministry of Finance. Would that still be possible today? I mean, we live in a completely different environment with lots of competing, you know, budget pressures like defense, etc. Would it even be possible today? But how did you also use it 2 years ago? Maybe you can reflect a little bit on this.
Absolutely, thank you, and thanks also for this nice introduction to the topic, Minister. Because I took I took note and some points that I would also like to reflect upon now. I looked up a presentation I gave pretty much 10 years ago at the summer school San Servolo, and one of the areas was primary healthcare, because there was something that we learned a lot from Slovenia, from the Veneto region in a joint policy dialogue, and then we also came to the conclusion, what do we need to implement a proper primary healthcare reform? And I looked up the slide from back then, and I started with one point, that was, we need more than money. The second point was, but we also need more money. And the third point was, and we need to spend it more wisely. I think, obviously, well, that's easy, right? That's always true in a way. So I also agree that, I mean, time is changing quickly, and it always does. But if we look back 20 years from now, as we celebrate 20 years of summer school, I mean, in 2007, what was it? Romania and who joined the EU in 27? Who knows it? Bulgaria, right? Romania, Bulgaria joined. Slovenia got the euro. So, and maybe the most important innovation in e-health was actually coming from 2007, and that was the iPhone. I mean, it completely changed also the way how we understand health. So what we tried to do a couple of years ago was really to foster and focus on the transformation of the healthcare system. And that was one of the elements where I think also the colleagues within the Ministries of Finance are ready for us and knocking on their doors. If we particularly discuss about the cost of inaction and the necessity of actually taking action. Because in the end, I mean, it's very easy. Policy making is about making decisions, but then also implementing decisions, which is why I'm also quite curious. I mean, I wrote down some of the points from your 15 points program, because I guess this is something that in politics one tries to avoid, because it is also something where you can get measured, right, in the end. But I think we need those objectives. And we also need, I think that's what politics is about, is also sharing what are the priorities, what do we want to achieve, because otherwise there's nothing to focus on in our daily work. So what we did was really to try to allocate money, and those were better days. I think those days, it would not have been the same discussion as now, but it was not as good as if we would have had this discussion 2 years earlier, because then health was still on everyone's agenda. So I think, again, we see this kind of roller scooter feeling that it changes so quickly how the priorities change within the political debates. And what we said is we want to install a new fund that is supporting transformational changes of the healthcare system. What we see now, if you would ask me if that was successful, I think partly yes. But on the other hand, we see all this budgetary pressure, and obviously it's so much more tricky to solve the next year's budget than to focus on the next 5 or 10 years' time. So we see a lot of this money being actually used not for transformation, but to make the next year's budget. So instead of really using this money now to shift care outside of hospitals, to build up capacity in the outpatient sector, we see that it's used also to cover the running deficits in hospitals. This is not what we planned, but we also understand the necessity to do that. So I think there we really need better strategies how to implement those structural changes that we need.
Do you have strategies already that you are exploring, or are you getting inspired here in the summer school and things that you can do? We've been talking a lot about how to make the investment case even in these difficult circumstances. What is your thinking here, or are you in the middle of it?
No, I mean, this was, I was also curious on the answer how to finance such healthcare reforms. I think maybe that was also a bold political decision, even though it sounds like a no-brainer, was to actually a commitment by the entire government to strengthen the solidarity-based healthcare system. I think it's really this looking back on our values that makes Europe strong and that defines Europe. And the difficult situation that I'm most concerned of is not taking decisions, because often they are painful, but not taking decisions will not change the need for medical services by an aging population. So that implicitly is a shift to the private sector, and particularly to the private pockets. So I don't care who is providing the services as long as it's well regulated, but it's really, do we have measures in place that people are not left behind, right? And for that, I think would be important to also make the case. I mean, this is what we tried and pushed for, and also with colleagues from not so much the World Bank, because typically World Bank works more in non-EU countries, member state countries, but with the European Investment Bank, with others, that health actually is one of the central elements of any lending program. So that we make it easier to support important funding into the health system as a main and really substantial part of economic growth. So when we started to get engaged also with the European Investment Bank, we had to make the case and had to argue why primary healthcare is good for climate change and is good for gender equality. We managed on both, but the factor, if it's good for health, is not considered as one of the main principles that any a project that uses public funding is actually looking at. And I think that is something we really need to change to make kind of this stronger interaction between industry and health, but particularly also the use of public money and the health of our population.
They're interesting ideas, and I will give also time for the others on the panel to reflect to this. But now I want to take it one step up. We were now on the national level. I'm going now to the European Union level. Cristina, we know that the Commission has several tools and instruments, the technical support instrument, but also perhaps the semester recommendations. What can you do also to improve efficiency in the member states?
Thank you very much. Yes, of course. I mean, at the European Commission, we never tell countries how much they should spend on health, nor how to organize their health systems. These are national competences and remain so. And it is, I would say, important for every country to find their own path. In the European model. But at a European level, what we have is we have a toolbox with several tools to create this dialogue and create opportunities for countries to identify reforms and then to support those reforms. Because we know that sometimes at national level, reforms can be hard to achieve. And often having an external partner that walks with the national level through the challenges and looks at what can be done can be helpful. And so if I'm to describe a little bit the toolbox that we have, it has several components. First of all, there's a component of information, which is a bit like evidence gathering, benchmarking, and this is where we work a lot with the Observatory because we have the state of health in the EU cycle, which is a 2-year cycle. We have a general health at a glance report, and then we have country profiles and a synthesis report where we delve in specific topics that change from one cycle to the next. And I think this is very important, and the feedback also that we have from national level is a very good one, because this is an exercise that allows individual countries to look at how they perform and also compare and benchmark themselves with other peers from the European Union. Then we have the process and another category of tools where we look at policy. And there we have, of course, the European semester. That is a very important tool for us, where we have this dialogue with the government, where we look and try to see with governments where is the money spent inefficiently, what are the areas that need special mobilization for reforms to move forward and for the longer-term fiscal sustainability of the country. So that's again another very important process, which is a sort of a dialogue, because we start with some general assessment, priorities, and a general overview. Then countries make their own assessment and plans, and then we have the whole dialogue that results in the country-specific recommendations. And these are for us very important tools to connect and discuss and identify these areas. And then I think what is very important and what we try to address as well is look at how these reforms can be implemented, and that's where the technical support instrument, and I think many countries have benefited from this in the health in the health area comes in providing technical assistance to design and implement reforms. And of course, since 2020, we had the Recovery and the Resilience Facility that has provided funding that was clearly linked to an action plan, to concrete targets, it was clearly linked to reforms that countries were committing themselves to implement. And I think we've seen across countries, and I think in the summer school we have the opportunity to delve in more in the concrete examples, but we've seen countries that started with country-specific recommendations in the economic in the European semester in 2020 that then addressed them through the RRF and received financing, and it's important amounts because we speak about 42 billion euros invested in health through the RRF at EU level, and accompanied with projects in TSI that really have translated into very concrete decreasing of waiting times, improving access in terms of primary care, and very clear indicators where we see now improvements, and I'm sure that some of the results of these efforts will also be seen in the next years.
Can I ask you one thing about the semester recommendations? It's my sense that they've become much more targeted, much more precise, as you will. Is that something that you would agree with? And can you reflect on that? And how did you achieve that, perhaps? Or maybe also a national perspective later?
I think, of course, I mean, from a European perspective, we have to balance this delicate, equilibrium in, of course, not, giving the country the ownership and the decision power on how to achieve it, but at the same time agreeing on what the challenges are and looking at the objectives in as a precise way as possible. So indeed, we have tried at European level to become to be more specific, because I think that's also helpful at national level when there is a very specific recommendation to mobilize the whole administration, the whole government, to get the financing, to get the stakeholders on board. So I think this is part of, as I say, a dialogue, and of course with some countries has worked faster and better. For other countries, it works best if we stay a bit more general, but the idea is to be as targeted as possible.
Maybe I'll ask countries to reflect on it now or later. I can maybe ask you later. First, I'll go to, again, a step up. We leave the European Union, we go to the European region, TRIN. We've known each other for a long time. We worked on financial incentives, we worked on purchasing. Some people seem to think that financial incentives can solve everything, but after almost 20 years working together, do you feel still that same way, or is that not enough, perhaps?
Thank you, Ewout. Indeed, it's more than 20 years. Incentives do work. Of course, they do work. They are not always working as we expect them to work. So and maybe like it's for me like it's to understand like the design of the incentives and how incentives are really like one thing is to design incentives at the system level. And then to see how providers are reacting to these incentives. So I need to go back to my period, like it's a pre-WHO period when I was working in Estonia, in the Health Insurance Fund, but also in the ministry. And I believe like it's when I got really like it's a very like it's blunt, like it's feedback was, I believe I was working at that time already in the ministry. Working on care integration, multidisciplinary primary healthcare centers, and visiting one of our most respected hospital managers, still is a very respected hospital manager, telling all the great plans we have there and how we also plan to change like financing and incentives around it. And he said, yes, Trine, of course, you can change payment incentives, payment methods, you can do that. And yes, we start to report you as you expect us to do. But, to be honest, we continue to do what we are planning to do. So I think it's for me, it's that kind of feedback was really important to actually to understand that one thing is how we see it's the goals, system level goals, when we are working at the system level. But then we come up with great ideas, we start implementation, but when we take a provider perspective, then their goals and how they see all our great ideas might look somewhat different. So it means that I have less salary to pay for my stuff. If it means that I might have it's a less utility cost, then I will figure out how I will survive in this system. So I think the first it's a very important lesson learned is to align goals. So we need to work with a work system level. We need to work together with the providers that our goals at the system level become also their goals, and then we figure out these ways how to design these incentives. That is really it's a win-win situation. Not it's that yes, we take money away it's from you as a hospital, we give it to primary healthcare, and you will figure out it's what you will do. In theory, it might sound it's a desirable it's to increase efficiency, but then we start seeing it's a huge resistance, and our great plans just stay our great plans. So and another the point there is as well if we increase efficiency, we always say that we want to get it from acute care to the primary health care, it's the prevention and then disease management. It all happens more there. Is our primary health care ready to absorb it? So are we putting enough resources there, and how we are putting these resources there? So and then there, because why I was visiting that it's a hospital manager was related to that investment it's a program, EU funding it's to primary healthcare centers to shift to multidisciplinary primary healthcare, because what we really realized we expect primary healthcare to do more. But if your starting point is small, it's a solo practices, it's a doctor and nurse, then through payment incentives, we can't switch to it's a big health centers and multidisciplinary teams. So you need investments into the infrastructure, which is a physical infrastructure, digital infrastructure, and unfortunately at that time there were no TSI projects, so it's a kind of soft component, it came somewhat later, but definitely you need to put also there to train staff and to support it's a development of new models of care. Yes, these are, and another one why maybe also it is important, because if we are just shifting care it is to the community level, out from it's at the hospitals, and if that level is not ready to take that part, then who should take the burden? A household. So people need to start taking care of their relatives and family members.
Okay, thank you. So actually you said goals, but could you also say we need a common vision and everybody needs to sort of agree and come together on that one? Is that often what is missing in your view in what you see in your international work?
If it comes to it's really the different stakeholders, of course it's at the a high level we agree, yes, we want all more efficiency, but what does it really mean, how it translates into actions, what do we need to do, how I should transform, or how should I act differently, and okay, even if I understand what is expected from me to do different things, but am I really willing to do that? Is it my goal as well? Do I really take that goal seriously? So it's what are incentives there?
Again, the question, what is efficiency? Okay, but I'm still going to ask Ajay about this, because now we're going global. We leave the European region even. You work, Ajay, mostly outside the European region, and often also in countries with much lower budgets than the countries in the European region or the EU. Yeah, it's on. And I was wondering whether you see important lessons in countries and how they set their priorities with much lower budgets that maybe we can learn from here in the European region.
Sure, thanks, Ewout. And Before I start to answer, I just wanted to also, so I work primarily in Asia, and Minister, we are joining you very soon in terms of population demography, right? So Asia now has some of the lowest fertility rates in the world. South Korea, Japan, China, and population's already declining. And to that, you can now add India. India's fertility rate is now below replacement. So the challenge in Asia is that it's going to become old before it becomes rich. And so some of the issues that you were pointing out already being faced in Asia and in a much tighter fiscal environment. One other thing to keep in mind is, of course, the budgets are usually smaller, especially in low and middle income countries, but also the cost of healthcare is also cheaper, right? It's healthcare is a labor-intensive industry, and the costs. So it's not that it's such a sort of binding constraint, but just keeping that in mind. So I'll sort of give you three sort of examples or lessons, picking up also from what Trine says in terms of what it is that the health systems are trying to do, where is it that they're trying to deliver care, and who is delivering the care. So not to add or repeat what the panelists have already said, but I think one point I want to make is that when you're looking at HTA or prioritization, it's not really always about saying no. It's also about proactively and very aggressively following, trying to get at high-value care. And so it's not only about incentives to providers, but also sometimes providing incentives to the patients themselves. So the example I'm thinking of, again, the problem is not European, but the principle that is there that, conditional cash transfers, for instance. In India, there's one of the largest conditional cash transfer programs that gives a small payment to women to deliver at health facilities. And, that whole idea of trying to encourage utilization for high-value care. So even though you may spend a little bit more by giving an incentive to women, you're gaining so much more in terms of reductions in maternal morbidity and mortality. And that same principle is extended also for chronic care, for NCDs. For instance, in Thailand, you have fee-for-service carve-outs for certain preventive care services. So you want people to come in and use mammographies and also for those types of things. So I think we need to also think about incentives sometimes to be given to the patients themselves, not just to providers. The second example is really about where is care being given. And here I think perhaps Asia has a bit of an advantage over Europe. So a lot of countries in Asia are now providing doorstep screening and medication deliveries for things like diabetes and hypertension. So at home. Sort of leveraging. This is trying to make sure that care is getting access to care is not a barrier. So you have huge cadres of community health workers that are going around. For instance, every single Indian now above the age of 30, every single Indian. This is 1.4 billion people. Is to be screened once a year for hypertension and diabetes. And every 5 years for 3 cancers and the like. So the point is there was so much undetected, uncontrolled diabetes and hypertension. It was far more cost effective to try and get that population level screening so you're catching things early and trying to manage it at the primary healthcare level rather than allowing hospitalizations for ambulatory care sensitive conditions. So, using, trying to do that screening also, and also providing delivery of medicines at home so that you don't even have to go to the pharmacy. So things come, in Thailand, they deliver refills and things like that by mail. So trying to remove that barrier to adherence for medication and making it as easy as possible. And also, in some cases, for low complexity care, allowing pharmacists to manage that. So is another option that's, Thailand has just rolled it out last year to try and leverage sort of where is it that care is being provided. Sometimes at the doorstep, sometimes in pharmacies, to try and improve that access. And final example, it's also, I've already alluded to this, but it's who is it that's providing the care. And I think this is where the task shifting, a lot of examples in Asia where you're using, the original example is, of course, the barefoot doctors in China, that they were not really doctors, they were health volunteers who had some medical training, who went around villages, but that's being sustained in many other countries. So Thailand itself has 1 million, these are voluntary health workers. Brazil does the same, Costa Rica and the like, and they cover maybe 10 to 20 households. And they really help you navigate the health system, but also help you understand importance of prevention, about adherence to treatment, risk factors, and the like. And you have similar task shifting. So if you think of this as clinical time that's there as being a constraint, you're now trying to get, by using community health workers, you're trying to take that constraint and trying to get more health from that time. So they're very closely supervised by clinical clinicians, and so it's not about just leaving it to the community health workers, but trying to get more from limitations that you may have in terms of availability of time of doctors and higher level care. So just to end, it's these sort of innovations in what is purchased, thinking beyond just HTA, but also proactively trying to get at high value care. Where is the care being delivered? So innovations in terms of reducing distance, but also who is it that delivers the care. Some lessons potentially from Asia.
Thank you, Ajay. Maybe some of you would like to reflect on what you heard. I see many parallels of what we have in Europe, but it's often slightly different, but it has the same thinking behind it. But I don't know if you, Valentina, and then Stefan. No, Valentina, you start.
Thank you. It's really it's a great debate, and thank you for this inputs. I was just thinking, efficiency, because this keeps on coming up. What is it?
What is your definition?
Thank you. But it's in the end, it's really simple. I remember once I talked to the health minister of Cyprus. Because they were, and Minister of Spain, we were sitting together in a hotel, and we were discussing how do we do the screening for colorectal cancer. And they say, it's really expensive, because to all the population that we want it to be screened, we are sending the tools for taking the sample immediately. And I said, really, you do? Because in Slovenia we don't. We first send the letter to everyone in the target group, asking them if they want to participate. And only if they reply and the postage is paid, we would send them the tool for taking the sample. And they were, wow, this would be cheaper. So, that's increasing the efficiency. And it's really small. And it saved the cost for Spain and Cyprus because we were sitting in a hotel and discussing. So, it's these little steps and little measures that we can do, but I don't know why we don't talk more, because we spend so much time together. We have all these benchmarking reports that you were mentioning, and they are not really, I don't know, do we listen to each other really closely enough, to understand that we can transfer good practices and experiences from country to country? One of the examples that and then I'll stop, so don't worry, is, for example, the issue of overproduction that we've been talking about so much. WHO, I don't know for how many years you've been calculating that there is like 20% of unnecessary services, and we are still talking about we have waiting list, we have to increase the production, we have to increase the production. And Wilm this morning or yesterday was telling us about PROMs, patient-reported outcome measures, And you know, in UK, when they started to measure the outcomes of the patients for the hip replacements, many of the patients, like 1/3 of the patients on the waiting list for hip replacement, saw that their health after the surgery, after the hip replacement, didn't improve. So they changed their mind. They took their name off the waiting list. You know, so that's a tool, measuring outcomes, measuring quality, is it good for patients or not? And that's efficiency also, you know? So just comment.
Thank you. I thought that Stefan, you were already writing things down, and so I'm very curious, your reflection.
No, I would have the very boring, much more boring answer to efficiency in the technical efficiency and allocative efficiency if we really look into that. And I think both elements in health are so difficult but so interesting, right? That we really make sure that we, and I think for technical efficiency we do have had some focus on it. We have all our data development analysis and other instruments, but on allocative efficiency, so that's we spend resources on the mix of services that deliver the most health and welfare. We do way too little in my view, and then we really have to see how we can increase efficiency there, because this is also the changing landscape after 2, 3, 4 years that I was pointing to earlier. I think now it's really, and I like it, Ete, you pointed to high quality care where we need to incentivize. I totally agree. But if I come with the concept of low value care, I mean low value care, if we also follow the European expert group, we understand it that we either invest too little in areas where we should invest more, or spend more. Invest maybe is a difficult term in that regard. But at the moment, I think the timing is more to focus on those areas where we get very bad quality, sometimes even a problem because we have over-medication, etc., and we pay a lot. So I think now is also the time really to focus on low-value care and remove low-value care out of the system before we introduce measures that hit everyone, and also high-quality care. So this and high-level care. That is, I think, one of the areas, and there maybe to try to make the circle to the European semester, as you asked. I think also there we see a changing landscape. I mean, I was always a friend of and a strong believer of cooperation also on the international level. So we always understood the European semester also in that regard. Because on the other hand, you could understand it that there is somebody from the Commission way overstepping their competence because of Article 168 of the Treaty of the Functioning of the EU, right? So health is a national competence. And then throwing you the ball on your playground, on your garden. And I think that changed also massively, because now there are supporting tools, and I think that was necessary and important that the Commission developed in that direction, that it's not only throwing the ball over to your garden and then, well, the ball would be nice to play alone, but maybe we also have other pictures in mind, right? But now is to accompany the way and more working together, and also strengthening collaboration between countries. So I think that is something where we really go into, and I look also to colleagues from the Czech Republic, for example. The new and old minister is very keen on cooperation. I will meet for a policy dialogue very soon, where we also discuss the concept of hospital at home. So really changing the way we deliver care, we understand hospitals, and I think that is so necessary. We had also there a discussion that was always kind of this. We always came to the question of a hospital. Almost always, it's the wrong patients at the hospital. It's the wrong kind of services provided in hospitals. And I think we really need to focus on the positive image. What is the role of a hospital in the next 20 years that we actually see necessary and that we want to achieve? And that is a lot different than it is today, I would say.
I see you nodding, Trin. Do you want to come in here?
Yeah, not exactly on that, but really like it's no, not. I totally agree with you because I think it was related to what I was earlier saying. Like it's what is it like what are interest of hospital manager? Like it's to kick out patients from the wards if it means that it's next year like you have unemployed like doctors and nurses. I was rather like it's thinking that what we see in several countries is that health financing community and community who is designing service delivery side, they work in silos. It's a financing, like it's the people design incentives. They talk about like it's exactly like it's efficiency analysis and how to increase technical efficiency, allocative efficiency. Then let's say the fee for service, DRGs, like it's all this doing simulations and modeling and all that stuff. And then there are like it's parallel world, like it's the people who are like it's thinking like what primary healthcare should do, what the regulation around that should be, like how our hospital network should look like. It's what they should do, and they not necessarily in some countries they come together, but not necessarily in every country they come together. But I must say that it's again like it's to make a progress to reduce these avoidable hospitalizations and all that. The probability of achieving that is much higher when these like it's the communities come together, because before that I mentioned like it's the providers and then purchaser, they need to come together, but also like it's a purchaser and like it's people responsible at the decision making level, like it's in regulating and then developing service delivery models, they need to come together as well.
Is there anything, Cristina or Ajay, you would like to react to? Otherwise, I have a concrete question for you, and then I'm going to go to you to ask for your questions. I know you have many because you've been, participants in the summer school. You're full of questions, so I expect many of you. Just warning you already. Sorry, who wanted to go first, Cristina?
Just maybe one or two small remarks. First of all, yes, indeed, I think it's very important to be able to distinguish between inefficiency and underinvestment. And sometimes we treat inefficiency as underinvestment, and then we are surprised that in the long term things don't improve. And then, secondly, to come back to what Valentina was mentioning about sharing experiences, we are firm believers, and this is very much anchored in the U4Health program, this idea of getting countries together through joint actions or through different tools to work together, because we believe there's great value in learning from each other. But I have to say that it's not easy, for us to defend this best practice sharing with the budget authorities. And I imagine that it's the same at national level, because when our budget, authorities ask, and what are you doing? Well, we are sharing best practices. It often looks like we are meeting to have some fun and and it's been challenging for us to make the case, and we have come with concrete examples, because I would say outside, let's say, the health world, it's not easy to understand why it is so important to sit together and to learn from each other.
I couldn't agree more, obviously, but I'm the director of the European Observatory on Health Systems and Policies, so keep pushing for that. And it is, of course, important that we also show the impact these meetings have, and we need to figure out how to measure these, because we all agree, but maybe it needs to be some form of evidence. Ajay.
Maybe I'll just add to what you were saying. Just the point that underinvestment can also be a source of inefficiency, right? If you just think simply that you build a hospital and then you don't staff it properly, that's a waste of money on the hospital. Or if you have a hospital that's staffed but you didn't train the health workers properly, that's a waste of the investment. So sometimes I think it's very important to make the point that even for, health is a production. So to have that minimum production function work, you do need a minimum level of investment, and otherwise it will cause inefficiencies.
Okay, so I'm now turning to my audience, to Raul, of course. Here I come.
Thank you. I have two questions. First, for Valentina. Slovenia has lowest catastrophic health expenditure, and it's leading in social participation and also community engagement. This is inspiration for many other countries. How did you achieve it? And is it sustainable in the next 10 years? Because we are not minister anymore, there is a new government, and then is it sustainable? So this is a question for you. And for Stefan, my question is about access to care in rural areas, because you talked about investing primary health care, strengthening primary health care, and the problem of rural health is not only low and middle income country problem, it's also European problem, because we talked to colleagues from Finland, Poland, and the UK has a group of GPs called GPs at the deep end who works in the rural areas. That's a huge challenge. And the director of European Forum for Primary Care, Maria, in one of the forums, she said that we call some group of people hard to reach people, but actually it's easy to ignore politically. And my question to you is that how we can make sure that in the rural areas we don't ignore them, and we have the primary healthcare doctors in the rural areas, because if you don't have a doctor, then you don't have the care, and the transport is a huge barrier to access. Thank you.
Shall we immediately answer, or shall I get some more questions? Are there more questions for now? Otherwise, I'm just going to volunteer. Oh, here.
Thank you, everyone, for this great presentation. So my question is related to the primary healthcare prevention and promotion. So I have heard, and many of us, that this is the area where we do need to invest more. And so we are hearing it's quite a lot of years already. So since you are ex-ministers or people who worked in the ministries of health, what you would do differently to actually prioritize these areas and invest more, ask ministries of finance? What would be your suggestions to take home?
Especially in this environment, I would say, add to that with all these competing pressures. Shall we try to answer? I think the first question was for you, Valentina, and Stefan, but maybe you want to kick us off.
Yeah, thank you for the question. Yeah, we are very proud in Slovenia of our very low catastrophic expenditure, and it's connected to low out-of-pocket payments. And it's all connected to our system of social contributions and complementary health insurance. And also, since we abolished it a couple of years ago, it's connected to the fact that all the services that were previously paid by the complementary health insurance are now paid by compulsory health insurance. So we actually, we kind of replaced. And what did it take to replace this? Because to have more money in the compulsory health insurance instead of complementary, it really takes will, dedication, and setting health as a political priority number one. And I think in the government that was ruling at the time that abolished the complementary health insurance, that was the real will. It was the support that health is number one priority. It was actually the values and really belief. That's why we managed to keep the system as is, and I'm very, very proud that we are still very low on OP and the catastrophic expenditure. Regarding the social participation, we have with us Vesna, who very much supported always social participation, and I think the best idea in social participation that I heard was the inclusion of young people. I enjoyed it so much when she brought the group of young people to me to present their ideas and to defend all the changes that we wanted to do in the healthcare system. Just bringing different stakeholders, especially young, and explain to them what the future will like in healthcare, it's something that gives you energy. So social participation, I think it's something that is worth every effort. And I'm glad that Slovenia is leading that way. And if I may answer to you, what would we do differently? We spent 3.7% of total health expenditure on prevention in Slovenia and about 1/3 on primary health care. And I think it's not enough. It's not enough. 3.7% is not enough. I must go back to the benchmarking. It's very difficult to benchmark what you do with the prevention programs. What do you count among preventions? For example, we have these centers for preventing mental illnesses among young and elderly. Would you count this as a prevention? We don't. But in my opinion, we should. So, first of all, when you compare this data among countries, it's not clear because each country has different prevention programs. First of all, there is screening. Okay, we can compare the screening, but there is then prevention programs which should be tailored according to the needs of the population. John was showing the graph when the public expenditure on teenagers, you remember yesterday, are higher in Slovenia than in other countries. You know why? Because we defined that in Slovenia, teenagers have issues with mental health and obesity. So we invested in prevention program for teenagers to move more, to do more physical exercise, and for mental health preventions to be available all of the time. That's why the expenditure in this age group between 14 and 16 increased. So, that's something that we should be doing, to tailor the programs according to the needs of the certain population. Yeah.
Stefan, I think you wanted to.
Thank you. Yeah, maybe to the first one, that was actually a topic, and it is here to stay in rural areas. And changes in primary healthcare was quite interesting because we also, and obviously we also did not agree on that question earlier, but we managed to get EU funding to then have an expert group that was brought together by the Observatory work on the question how we could ensure more continuity of care and particularly interest in care in rural areas. Because what we tried to do for many years in different ways was, and I shared it today already a bit, and yesterday, was to solve it through the use of money. So if you would be willing as a doctor to serve and have your practice in a rural area, you would get an additional payment, either one-time payment or higher payment regularly. And this had very little effect, and this is also what the evidence shows, right? But the problem was we were not really happy with the evidence that was provided then by the colleagues of the European Observatory, because in the end there were two very strong measures with a lot of evidence. One was having a doctor who grew up in a family where one member of the family was working as a doctor in a rural area. So that is limiting you, but obviously if you know how this career being a GP in a rural area is, that is actually that was behind the driving force. But you cannot count on children of doctors who worked in rural areas, because that is not a very concrete measure where you can start with in the first place, right? So it was more the underlying factor that as soon as people were exposed to that way of working and also on the advantages, because there are also some advantages, that helped a lot in making sure that more people decide and are ready to work in rural areas. So that was one of the programs where we saw some evidence, because if you study in the capital and at the university, you cannot imagine working in some rural areas. So that was one of the elements, but more and more that changed also with the need for more flexible models of care. So not being, and in Austria, our GPs are organized that they are typically in solo GP practices, is still the dominant form, and you're responsible for your own business. You have a contract with the social health insurance, but nobody wanted to take that financial risk, because if people move outside of rural areas, then you cannot have the frequency needed to actually have a proper income. And what we try more and more is this kind of network models, where we provide care for some days in those areas, and also coming from bigger primary healthcare units. So that could then serve kind of as a satellite where you provide care in those areas, because we see the tendency, even if we provide incentives, people do not take this decision anymore to work in rural areas. So that is more what we are aiming for. And also on the question on how to what to do differently, and I find that really impressive for primary healthcare. If you look on spending for primary healthcare, I mean, I would argue that the evidence of the use of a strong primary healthcare system is almost conclusive, if not conclusive. If you look at the Declaration of Alma-Ata, 1978, if I get it right, it was everything there already, right? So, and it doesn't need so much changing over the time, but still we did not manage to invest properly, and preventive services is even much worse, obviously. And then sometimes, and now I need to be careful, obviously, but I think we need to be smart in finding ways to combine a short political cycle with this long-term impact of prevention. Because obviously you need very brave ministers, and luckily they exist, right? And we have brave ministers every now and then to really not care about the next election so much, but really wanting to make a difference in the system. And I think this is for prevention such a difficult way, because I understand also the need to solve problems of the next year, and then making sure you have time to focus on 10 years away from now, or 20 years away from now. But maybe there is one take-home message to make sure that we are stronger in all of the dimensions we discussed today. And that is maybe the next EU budget to also try, and I think, Cristina, you said sometimes it's easier if we have a strong partner, and if you are involved in, can say, well, we know prevention, I know there is no quick win, we know it is something you do for the health system, but not maybe for the next 2-3 years. But if we can manage that we have a success, that this is strengthened also on the EU level, also working with the European Investment Bank, the World Bank, other institutions, that is something where I think also today you have a success, because we got better in anchoring prevention in the systems, even though the result will come much later. And I think that might be one of the areas where we really need to be more innovative, not in the way of evidence that we need. And this is also my concern. If we talk too much about e-health, digitalization, AI, we lose the side of this kind of very boring areas like prevention. But we need to combine them better, and we need to make sure that we are more innovative how we implement it. I think sometimes it's not the innovation per se, but it's the innovative approach, how to make it happen in the end.
I think we go to the online audience. There was one question, and then we'll wrap up, because we're approaching the end of our time together here. Is that correct?
Can I ask a question? Actually, a question to Ajay. I think that the example you gave was very beautiful, to see how countries in other regions with less resources have to be creative to reach out the population. And this could be very beautiful examples for the European region. And I wanted to ask if you know about the quality of care that these community workers provide, and some volunteers, if this is something that Europe could be adopting. I know that, for example, we had discussions about the Nordic countries that have difficulties in providing care in remote areas, so maybe this would be an idea. The second question is if it really improves efficiency, because there is evidence from the US that when they try to delegate some tasks from GPs to physician assistants, it reduced the payment to salaries, but they created much more referrals to specialist care and many more diagnostic tests. So if this is really efficient. And maybe the last question is, how did the physicians in the Asian countries react when the government or the system delegated the part of their tasks to these other professionals?
If you could try to answer that briefly, and then I'll give everybody 10 seconds with their key message, so you can already start thinking, dear panel. But Ajay, this question was for you.
Yes. So, yes, I think it depends on it's just, you don't just say, oh yeah, use community health workers and it's going to solve the problem. The devil is in the details and the design and what is it that you're trying to solve. And I think one point is that you want to have them work very closely with the doctors and the clinicians, so not independent of that. So follow up and I think, and it really is seen and sort of sold as a way to improve the efficiency of clinicians. So it's helping them do their job better, more effectively, and perhaps in the long term reduce the burden of them having to provide that care. So if, for instance, there isn't that room in this community or the society, of course that's going to be far more difficult. But the idea here is to if, for instance, you have people who are willing to work part-time, for instance, so a lot of time the community health workers are women who are not working full-time. They're officially classified as volunteers who get a stipend. So if there's that kind of labor room in the community that could be leveraged, this is also how the Chinese barefoot doctor program started. I don't see why it cannot work, and especially combined with an aging population where you also need help with long-term care and the like. This clearly is already being implemented in some cases, in some settings, and really it depends on whether or not there is room in the labor market to do so. But just also wanted to underscore the importance of prevention and promotion, and not just from a health perspective, but also from an economics perspective. And I think WHO should stop calling them communicable and non-communicable diseases. They're now chronic and non-chronic diseases, because once you get these, you're going to have them for 30, 40, 50, 60 years of your life, right? It's not like getting the flu. And they require a very different type of response, and from an economics point of view, to really delay the onset as much as possible, and not just focus on mortality, adult mortality, but also premature morbidity to allow for healthy aging.
So that was probably your final message to the audience here. So we go to Cristina.
From my point of view, I think, of course, what I take from the discussion is, of course, they're big objectives, but sometimes very small actions go a long way. And sometimes of course, we need to build towards the big objectives, improving prevention and working in a coordinated way at European level, have a structural long-term perspective. This is extremely important. At the same time, let's say, the forest is made out of trees, and I think that every single measure that improves the outcomes for the patient are building blocks, and we should see them as building blocks of a long-term project.
Valentina, can you go now, or yes?
I didn't prepare, the final statement, so, yeah, I think what we should do is to go for a shift in society values. I think we've been talking and throwing these big words around that we all believe in, like equity, sustainability, gender equality, efficiency. But, we've been talking about this for 20 years. And we need to do something to make a real change towards prevention. We want the young people to live healthy. So I would say the main key message would be to connect healthcare to education system. Just tell them, what is it to live healthy? Because each year that we don't do this, we lose a generation. So for the future, let's focus on the young and tell them how to live healthy, because I believe that prevention is the most efficient way to go.
Very good. Stefan.
Thank you. Yeah, I think also reflecting on the panel on this week so far, it is really about making sure that financing and all the different elements of financing in a healthcare system are not understood as technical questions. They are at the core of the future of our solidarity-based healthcare systems. And I think this combination of really having the examples, knowing the theory, but connecting it with practice and being aware that what we do when we come up with good solutions towards the a long-term sustainability of the healthcare system is so important. So it's really much more than the theory and the numbers. It's really about making a difference in the end. And yes, in all our areas, we sometimes talk too much and do too little and act too little so that we really get it done. And I think that is really one of the areas that we should aim for, and maybe connecting it with the prevention is being prepared before something happens. So not being reactive, but really being active and seeing it coming and planning the future and not reacting to it. I think that is really what we need to do, should have done, but need to do now. Better late than never, right?
Trin.
Yes. Also reflecting, like it said, what was discussed, that we should learn more from each other, from countries learning from each other. And then coming to, like it's the payments incentives. So it's of course, like we need to look like what other countries are doing, what is working, what is not working. But we definitely need to understand the context where these incentives are functioning, and what is our own a health system context. So it's how our provider network is organized, how much managerial autonomy our providers have, what is a regulation in place, plus what are accountability mechanisms and reporting requirements, because it is payment incentives are just it's a more small piece, it's in this broader, it's a very complex health system. And then when we if we want them to be effective, we need to to understand these complexities. And of course, we need to understand how these incentives look from the provider perspective.
Thank you, Trin. I would say a round of applause for our panel here. And I will give the final word to Minister Gerosa, who's been listening very carefully. And so I'm really curious to hear what he has to say, or maybe a short reflection, and I will ask you to close the meeting for today.
They asked me to perform the closing remarks. So a few bullet points, because I realized that I'm the last obstacle between you and the pizza, so I'll be very fast. So first of all, I truly enjoyed this debate. I learned a lot from the debate. It was food for brain, I think, for everybody. I learned that, let's say, very informal brainstorming are apparently extremely important. I learned that, when discussing the Spain minister, with the Spanish minister, with the Cyprus minister, they learned in a very informal brainstorming how to act better in order to prevent colorectal cancer. So I think we should provide more informal brainstorming from this point. And then I learned, I loved the sentence, the issue, we need more than money, but we need more money. We need to spend better money. I love that, absolutely, and it's true. And also, and I totally agree, we should prevent rather than react. This is a very important, crucial point. And also, I love the fact that prevention plays a role. But also, I think we should state another important factor, that citizens at the national and international level should take responsibility of their health. It's very important to provide healthcare services, but citizens should take responsibilities of their health with lifestyle, different lifestyle. And also, I truly enjoyed to learn and to listen a lot about low-income countries. That was very, very, very helpful. Thank you. I have no other closing remarks, and hope to see you next year. Thank you.